A very good evening to all of you. Myself, Dr. Vinder Kaur. I am professor and head in Department of Radiodiagnosis at GMCH Chandigarh, and I'm the secretary of Society of Chest Imaging and Interventions. I warmly welcome all of you to this webinar, which is, I think, third in the series. Earlier, two webinars were done on cystic lung disease and update on lung cancer. So this webinar is on the interesting pediatric chest cases, and I'm very thankful to Dr. Manisha Jana for graciously accepting the request for presenting this webinar. Dr. Manisha Jana needs no introduction. She is professor in Department of Radiodiagnosis at AIIMS, New Delhi, and she has special interest in pediatrics and chest.
Here we start. Now I'll be showing you 5 consecutive cases of opaque hemithorax. All of them started with opaque hemithorax, but the causes were very different. Let's see. So this is the first case, and he's a 1-year-old boy. As we see that there is an opaque hemithorax, opaque right hemithorax. Now, once we see an opaque hemithorax, the immediate question or immediate word that should be described is, where is the mediastinum? Is it central? Is it ipsilaterally shifted or contralaterally shifted? So here we see there is an opaque hemithorax on the right side with ipsilateral mediastinal shift. And this is a 1-year-old boy. You can post what you think in the chat box. Meanwhile, I'll start describing. So along with that opaque hemithorax, what else we can see? We can see that the volume of the right side hemithorax is much less as compared to the left side, as evident by the shape of the ribs. So there is, and the intercostal spaces are also a bit narrow. So there is a small volume or low volume or volume loss, whatever you might call it. And you can see this air shadow. This is the herniated left-sided lung, which is going to the other side, crossing. Okay, so foreign body. Foreign body is a very good thought. So foreign body is definitely one good thought. Now, if we go back to the previous image, why it is not foreign body? I'll come back to the point later on as well. So here is the trachea. I am following the trachea. So you see that the right border of the trachea is convex laterally. There is no carina, right? So if there is no carina, then unlikely that there will be any right lung. So probably we are dealing with a right lung agenesis. Foreign body can also happen in a 1-year-old kid. Actually, that is one of the commonest cause in a toddler. But here, this shape of the trachea and the carina is a bit against the possibility of foreign body. Now, a CT was done. Let's see what is happening in the CT. These are the consecutive sections of contrast enhanced scan. And here what we see, this is the arch, because there is no lung. So mediastinum has rotated to the right side. This soft tissue in the anterior mediastinum here, it may create a lot of confusion, but it is actually AIIMS. So here, this is the left pulmonary artery. See, it has got a long course like this. So this is the left pulmonary artery. Right pulmonary artery is not visible. But see carefully, is it really not visible? Yes, we can see a very tiny thread-like, very thin thread-like pulmonary artery arising, right pulmonary artery, which is arising. And where it is going lower down in the posterior costophrenic sulcus. We can trace it, this dot. So the next question is, if it's pulmonary agenesis, what is pulmonary artery doing over here? And where is the pulmonary parenchyma? Now the answer lay in the posterior inferior part of the right hemithorax. So there is one soft tissue which looked like that probably there is a small residual lung. And you see this nipple of tissue here, this contrast field structure, this is probably the very rudimentary pulmonary vein. So now as we come a little caudally, we can see that there is indeed a lung which is showing air shadow inside. So these are the air within the bronchi, and this is the pulmonary artery branches within the parenchyma. And maximum intensity projection images show the course of the pulmonary artery. So whatever lung it is there on the right side, it is at the lower part. So upper lobe is not there. Now, if we go back to the previous X-ray, this is a magnified view of this X-ray. So as I said that the right border of the trachea, it was convex outwardly, and there was no carina, no right main bronchus. So there is a parenchyma, there is an artery, there is vein, but then where is the bronchus? There was no bronchus. If we see very carefully at the lower part of the right hemithorax, there are some air shadows. Where did the air come from? If there is no bronchus, we could see no bronchus. Then where is the possible source of the bronchus? And our thought was also established by these MINIP images. This is the smooth contour. There is no right bronchus, but there is air within the lung. Where could this air originate from? This is the barium study of the child where the bronchus was originating from the lower esophagus. So instead of coming from a proper bronchial tree, the esophagus was coming out, originating from the distal esophagus. And the supply to the lung, vascular supply was maintained, although small, because the pulmonary parenchyma itself was very small. And the venous drainage was also preserved, but the veins were small, as easily understood. Now, if we see that this air, this is not participating into the proper gas exchange, because the air is not coming from the air. This is not tracheal air. And because food material also goes inside the trachea, inside this anomalous bronchus, so there will be a chance of recurrent infection. And that's how the child presented with recurrent respiratory tract infections. So it is best to remove this part of this abnormal lung, which is called esophageal lung. This is an extremely rare anomaly. Usually they are seen on the right side, a small lung which draws its air bronchi from the esophagus. So this is one type of congenital tracheoesophageal septum, this division abnormality, where the bronchus originates from the lower part of the esophagus. And as I explained, they usually present with recurrent infection and surgery should be done. This part should be removed. This is the treatment of choice. So this was one of, this was the first case of opaque hemithorax. And I'm just again going back and showing the contour of the trachea and the carina. So there is no carina. That's why the trachea and where it should branch, instead, there should be an angle which should be formed. We cannot see that angle. Instead, it looks like a smoothly curving trachea going into the left main bronchus. So this is what should prompt to think us that either agenesis or some other anomaly should be there. Now, coming to opaque hemithorax, second case. He is a relatively older child compared to the previous child, 10-year-old boy, who had a recent onset of dyspnea. And there were specific other symptoms, which I am not telling right now. But if we see, how do you think it is? Specific characteristic of the opaque hemithorax. So here what we see, there is opaque hemithorax, of course, on the right side, but it is very dense like that of the bones. So there is ossification or calcification going on the right hemithorax. This is so extensive that entire hemithorax is appearing very white. There is a little mass effect in the form of contralateral mediastinal shift, also not very much. In addition, there are multiple other very dense shadows, nodules on the left side, left hemithorax. We can see them. So, any thoughts? Okay, CT was done. In the CT, what we see that these lesions which we saw in encircling the entire hemithorax, they were actually not in the pulmonary space. They were in the pleural space. See how beautifully the pleura has been delineated by a dense, thick, ossified lesion. So it is almost like encircling the visceral as well as parietal pleura with soft tissue within. This is the pleural space, pleural cavity, and these are the ossification at the two layers of it. And the lung here on the surface, there is calcification, and this lung has been trapped within. The similar kind of pleural-based metastasis is also, sorry, I spoke it, this is a metastasis. So we can see this encasement of the lung by the pleura. So the lung is not able to expand. In reality, the number of pleural lesions are way too much more than the pulmonary lesions in this child. And the history was that there was a lesion, already known tumor. There was osteosarcoma of the left acetabulum. And see, this is the volume rendered image of the chest, which shows that almost the right hemithorax has turned into a stone. And there are multiple other small pebble-like lesions in the left hemithorax. And this is the lung, which has been trapped inside this ossified pleura. And here we can see the sclerotic lesion in the left acetabulum. So this was osteosarcoma metastasis in the pleura. We know that osteosarcoma can metastasize at many places, to bones, to lungs, to many other places, but pleural metastasis is unusual. Pulmonary metastases are way too much more common than pleural mets. When the pleura is involved with osteosarcoma, it can either be a contiguous spread from a thoracic osteosarcoma, or it can be a hematogenous spread, as in our case. So this was a very unusual appearance of like ossified pleural metastasis from osteosarcoma. Now, a third case scenario of opaque hemithorax in a child. The child is very small, probably the smallest in today's discussion. The child is only two months old, and she had a sudden onset of respiratory distress, which was preceded by viral infection. And the child was visibly tachypneic with chest retractions. So when the child presented, this is the chest radiograph. Here again, what we see, this is an opaque hemithorax, left opaque hemithorax with ipsilateral mediastinal shift. So what might be the possibility? Because the child is very small, agenesis should always remain in our DD in such an appearance, but this is not agenesis. Why? Because I can see the left main bronchus clearly. So here we can see the left main bronchus, and we can see the carina as well. Just if we compare with the appearance we had in the first case, and here we can see clearly the difference in the appearance of carina and trachea. In a very small kid in whom agenesis seems unlikely, and the child shows a opaque hemithorax with ipsilateral mediastinal shift. So, yes, one possibility might be that there might be a mediastinal mass which is causing left main bronchus compression, or let's see what it was. In such a case, when there is a given history that the child had a history of viral infection, preceding viral infection, it always pays to see the previous radiograph. So let's have a look at the previous radiograph. This was at 1.5 months. So 1.5 months of age also, the child had this kind of opaque left hemithorax with ipsilateral mediastinal shift. Also, what we see is that the right upper zone and mid zone also had parenchymal opacities. There were consolidation in the right upper and mid zone as well. If we see the intercostal spaces, they are not that much small. So there is not that much small volume of the hemithorax, but we can see that ipsilateral shift is already there. This is the lateral radiograph which was performed, which shows that this spine sign. So this lateral actually helped in the way that it showed it is a pulmonary pathology. Didn't add anything much in the in any other way. But here we can see the retrosternal lucency is maintained. So mediastinal mass it is not. It is a pulmonary pathology and it is bilateral. In the AP radiograph, we can see the carina very well. So both the bronchi are seen well. Now, this is the most confusing one. At 1 month of age, the child had such lungs. So at this point of time, the child had acute respiratory illness, and the child was hospital admission. Child had hospital admission. So at that time, what did she have? She had hyperinflated bilateral lung fields. So we can see the hyperinflated lung fields, the chest intercostal spaces are widened. And this is what is the interstitial pattern, the peribronchial thickening, peribronchial areas of consolidation in the left side, also on the right upper and mid zone, and extreme hyperinflation. So this is not a 1 month-old kid's lung. So we have to understand that there is predominant hyperinflation. So we have to keep a viral infection at that time in mind. Now, what may have happened that the child from that viral infection went to this kind of complete opaque hemithorax? Only one answer is that there have been a collapse. Now, what was the cause of the collapse? When a CT was done, we could see that there is a very low attenuation tissue within the left main bronchus, right above the, just after the carina. And the attenuation was -44, giving the impression that there might be fat within. When we saw that this is the coronal lung window images, we can see that there is definitely some intraluminal pathology over here. And this is the corresponding axial non-contrast CT, where we can see that there was this some intraluminal low attenuation soft tissue. Now, the possibility, keeping in mind the chronological appearance of the collapse, is first thing that should be considered is a mucus plug. We should not be misled by this low attenuation, because mucus mixed with air can give very low attenuation. Sometimes mottled appearance may be seen, which is actually quite characteristic. But if mottled lucency is not seen, low attenuation does not rule out mucus plug, because the air is mixed with fluid here. And and we can see on the right side also, probably that's secondary to this, the child may have aspirated. So there was dependent location consolidation on the right lung as well. And a bronchoscopy was planned and bronchoscopy was done. It is really difficult to do bronchoscopy in such a small kid. So we have to give a reasonably good diagnosis to the pediatrician so as to intervene. Like if it is a mucus plug, then a simple bronchoscopy might be life-saving, might be very beneficial for this child. And in this kid, on a bronchoscopy, no mass was found, and there was a mucus plug. Mucus plug was cleared, and post bronchoscopy, the lung expanded, not completely, but there was significant expansion. So what we had was a mucus plug. So the pointer towards mucus plug causing lung collapse is that first, very rapid onset of massive collapse of one side, blood clot and mucus plug. They are the commonest cause. Any mass would have been present. If it's congenital, may have been present since birth. So it may have taken a time, it is a slowly developing thing. But if it's a mucus plug, it can cause sudden onset, acute onset collapse. Second thing, when a child is having viral pneumonia, there is too much secretion within the airway, within the tracheobronchial tree. Those secretions, those mucus, they may get trapped anytime, in the smaller bronchi, or even rarely at the main bronchi, and may give complete lung collapse. More commonly, they get lodged in the distal part, giving rise to this post-viral atelectasis. To our fourth opaque hemithorax. So it's up to you whether you call it an opaque hemithorax or not, but it looks like an opaque hemithorax. Yet again, a very small kid, a 10-month-old boy who had tachypnea, visibly distressed, and had poor neck control. So there may be contention that when this is not opaque hemithorax, this is an enlarged heart. But if you have a look, how do you describe this? We can call it an opaque hemithorax with sparing, with visible distal, the claustrophrenic angles and the apex, and the cardiac silhouette is not well visualized. It might be a huge cardiomegaly. However, we can see that on the right side of the heart, it is not that much enlarged. On the left side, if it is a cardiac enlargement, then the left side is probably much more enlarged than the atrial side. And so the right lung is also visible. And why it is so much on the left side unilateral? The other possibility, and why there is not much mediastinal shift to the other side. The possibility might be that there is a big heart which might be compressing the bronchus, causing associated left lung collapse as well, which is not very well appreciated in here. The next mode of action, what should we do? We should do a bedside echocardiography. And for that, we don't need to wait for the cardiologist to come. We can simply put our probe for a focus, and we can see what is happening actually here. So cardiac cause is definitely on the cards over here. So that's why when we put and see here, doing an echo, bedside echo is not that much difficult, because if it is a cardiac cause, then almost like entire left hemithorax is filled with the heart only. So wherever you put the probe, you would get to see what it is. And what it is a big heart, a big, huge, thick heart. So this is the interventricular septum. We can see this interventricular septum this big. Not only big, the echogenicity is also abnormal. So the enlargement is not limited to the interventricular septum only. It is also limited to the free wall of the ventricles, both right as well as left ventricles. There is a minimal amount of pericardial effusion, not that much, but the majority of the shadow that we are seeing, that was due to this big heart with thick muscles, very thick echogenic muscles. Now, this is the appearance of hypertrophic cardiomyopathy. Now, this is in such a small child with hypertrophic cardiomyopathy and poor neck control. We had some diagnostic possibility in mind, and keeping that in mind, we did ultrasound of the tongue. Now, that might seem a little odd. Why tongue? So actually, we wanted the skeletal muscles. So, and especially tongue is affected in this specific disease. When we did the ultrasound, we could see that the muscles are unusually echogenic. So this is done from the submandibular approach. These are the mylohyoid muscles, but these muscles, if we see, these are the intrinsic muscles of the tongue, which are way too echogenic. Echogenicity should have been like this. They are way too echogenic. And so if it's echogenic, the natural consideration comes that probably there is fatty infiltration. However, when an NCCT was acquired, we could see that there was no fatty infiltration. Instead, attenuation was higher. So what can cause echogenicity and higher attenuation? It is definitely not fat. And similar appearance was seen in the paraspinal muscles. Also, echogenicity was increased in the epidural space. So if it is not fat, definitely it is not fat, but then what can be more echogenic? Glycogen. So it was diffuse deposition of glycogen everywhere. And we were dealing with Pompey's disease or glycogen storage disease. type 2. So the presence of this cardiomegaly, hypertrophic cardiomyopathy, and in a child who, in an infant rather, with hypotonia, poor neck control, they all point towards a secondary hypertrophic cardiomyopathy. And at this age, we should always keep Pompe's disease in mind. Infantile onset Pompe's disease is one of the causes that we should keep in mind whenever we see hypertrophic cardiomyopathy in a child. Hypertrophic cardiomyopathy in a child can be either primary or secondary. So in infants, secondary causes are much more commoner than primary causes. Infantile onset Pompe's disease is one of the commonest of them. Now coming to the last case of the opaque hemithorax group. This is the 5th case. So here, he's a bigger boy, 11-year-old boy, who had chest discomfort and cough for quite a long time. It is an insidious onset lesion problem, and presumptive diagnosis of TB was done. Child was treated with ATT without much improvement. So the child was referred, and when we see the radiograph, we could see that there is an opaque right hemithorax with ipsilateral mediastinal shift. The degree of mediastinal shift, you can see there is severe degree of ipsilateral mediastinal shift with compensatory hyperinflation of the other lung. All of these indicate pathology which has been there for a while, which has grown for quite some time, so that the expansion of the other lung has taken place. And the volume, if we see the right hemithorax, the volume is definitely less as compared to the left side. If we look at the trachea, now here comes the important point. If we look at the trachea, we can see that the trachea shows an abrupt cutoff. Right main bronchus shows an abrupt cutoff. The left main bronchus goes normally. And at the end of the right main bronchus, we could see that there is a meniscus sign or inward bulge with a meniscus. So all these features would possibly indicate towards an intrabronchial lesion causing collapse, lung collapse. Now, then traditionally, the next step of action would have been a CT. However, if we have an ultrasound probe handy, we should always try to see. And if we try to see, there are many more things that we can do with ultrasound. So when we place the curvilinear transducer over here, we could see that through the intercostal, this approach is through the intercostal approach, we could see that there are two appearance of the lesion. So this is the right hemithorax. We could see there is a hypoechoic lesion between the cursors, and distal to it or peripheral to it, we could see that there is this collapsed lung. This is the heart which has been in focus because of collapse. Now, the beauty of ultrasound, thoracic ultrasound, is that it can differentiate the thymus from any other thing so well. So here we can see this is the thymus showing the typical starry sky pattern. Just adjacent to it, we could see the collapsed lung with the parallel bronchi and the vessels. A color Doppler would delineate that better. So these are the bronchi filled with fluid. So fluid bronchogram with parallelly running vessels here. So that implies this is a collapsed lung. And central to that collapsed lung, what is there? There is a mass which is seen with definite, distinct, different echogenicity as from that of the lesion, from that of the collapse. So subsequently CT was done, and in the CT we can see this is the collapsed lung, and the difference, this is the mass that we saw so well on the ultrasound. So this is the mass which is having this interluminal component within the right main bronchus, and this peripheral part is the collapse. Now, if we see on a routine CCT, the difference between this lesion and the peripheral collapsed lung is not that well distinct. that well demarcated like we got to see on ultrasound. You have to accept that the difference is much better, much more pronounced on the ultrasound image. Anyway, for the planning of surgery or biopsy or anything, CT is needed. But ultrasound additionally gave us much more clarity about from where to take biopsy or what is the exact extent of the lesion. And here is the blown up image of the same. We could see that the lesion was a little more enhancing than the pulmonary parenchyma. And on biopsy, it turned out to be an inflammatory myofibroblastic tumor or IMFT. So here the coronal MPR as well as coronal MINIP image, which shows the bronchial cutoff. So this was an inflammatory myofibroblastic tumor. As you see that all of the opaque hemithorax, the 5 cases that I showed, all had very different appearances, very different varied causes. Some of them are very unusual, but just keep in the back of the mind that such kind of appearances may also happen. Some of them are like once in a lifetime case, but yes, if we know, then only we can diagnose it later on. Now, I will show 2 cases of lung ultrasound, where how lung ultrasound can help us in be it bedside in the ICU or in your routine OPD setting. So here in the lung, this is a newborn, term newborn who had respiratory distress, and bedside this was a radiograph where we can see what we see is that the volume. First, in a newborn with respiratory distress, we need to look at the volume of the lungs. So volume of the lungs is preserved. We can see some peribronchial areas of consolidation. Overall, the lungs appear of normal volume. That's why the newborn was a term newborn. So RDS or respiratory distress syndrome or hyaline membrane disease is probably less likely. But in such a case, should we go for a CT? No, better to do a bedside ultrasound in such a child. And when we did ultrasound in this child, so this is a sagittal view. You can see the rib shadow. What we can see, this is the cranial part, this is the caudal part. The baby is supine. So this is the cranial part where we can see a normal lung with reverberation artifacts with occasional cometal shadow, that implying this is a normal lung. But in the next intercostal space, we can see there is a granular appearance, loss of A lines and confluent B lines. So this is normal, this is abnormal. Then similar appearance at another, on the other side as well, we could see this is a normal lung with A lines and occasional cometal artifact. But as we go caudally, we could see that there is this granular kind of appearance with confluent B lines. This is taken from the posterior aspect in a sagittal plane where we can see confluent B lines. So if we are to grade the abnormality, so this area becomes normal, this is abnormal, this is a kind of white out appearance. So this is severe. So clearly we can see a gradient of abnormality versus normality in the regional distribution. So, and this is again from the posterior aspect, we could see in the intercostal space, these are the areas of consolidation when confluent B lines. So to sum up, the imaging finding was that whatever the image findings were there, they were inhomogeneous, more prominent in the caudal part of the lung and posterior part, that is the dependent part of the lung. So the upper part of the lung was having a normal appearance, the lower and the posterior part or the dependent part were having features of fluid overload. So this appearance is called double lung point sign, and this gradient of lung changes in the dependent location, both of them favor a diagnosis of transient tachypnea of newborn. Sometimes TTN may be associated with pulmonary hypertension. Sometimes TTN might be prolonged for beyond the neonatal period, which is also known as malignant TTN. But when we see this kind of imaging feature, we should always keep in mind the possibility of TTN over respiratory distress syndrome. And of course, we didn't do any CT in this child. Child improved in a while. This is the second case of lung ultrasound, a newborn who had an antenatally detected mass already. And so when the baby was born, we were called to the NICU. The images of the quality of the images are bad because they were actually taken from the focus at the bedside, on the beds, by the bedside. So what we can see, these are the sagittal images. What we see is that there is a cystic lesion, multiseptated cystic lesion. This was, the probe was kept on the left hemithorax, but there are multiple cystic lesion with septae within. And at the edge of the lesion, we can see some confluent B lines. So that means this indicates that this is in the lung. Here in this sagittal image, we could see that a part of the lung is showing confluent B lines over here, confluent B lines, and just after that, this mass starts. So mass is probably lying at the caudal end or the lower lobe of the lungs, and the upper part of the lung is also showing fluid, increased fluid within the alveolus. But since it was a newborn, sometimes delayed clearance of lung fluid can give this kind of appearance. A little more higher up and to the other side, we can see these normal A lines. So the right lung was normal. This is a thymus in the midline. A CT was done in view of the abnormality that we suggested and the antenatal imaging said. So what we see is that a big fluid and air shadow filled lesion in the left hemithorax. So this bubbly kind of lesion in the left hemithorax with contralateral mediastinal shift with two possibilities, CPAM or congenital diaphragmatic hernia. However, we could see by the appearance on ultrasound and also on the CT, we could very well see the diaphragm. So this was not a congenital diaphragmatic hernia. This was a CPAM, a type 2 CPAM of variable size. And ultrasound could demonstrate beautifully, maybe because of two reasons, that it was a newborn when the lung fluid was not yet cleared. Had it been an older child or an older infant, then the lung fluid would have cleared and the cysts would have been filled with air, making ultrasound less useful modality in evaluation. So this was CPAM. Now, one unusual case of pediatric ILD I like to show. So this was a 1-year-old boy who had neonatal onset hyperammonemia. The infant had coma, recurrent episodes of coma, and also chronic kidney disease. Along with that, recurrent pneumonia. So multiple organ systems were affected. When we saw the CT, what was the predominant finding? The finding was that of, septal thickening as well as ground glass opacity. And at some places, we could see the appearance of crazy paving, or we can see here the GGO with superimposed smooth septal thickening, giving rise to this crazy paving appearance. At the upper part of the lung, the GGO part was much more prominent, giving rise to consolidations at some places. So this is a blown up image which shows the crazy paving much better. These are the coronal reformated images and axial images showing the same. So the pattern was pulmonary alveolar proteinosis pattern. Now the cause of pulmonary alveolar proteinosis pattern in an infant might be very variable, but surfactant protein abnormality should be kept on the list, in the list of the differential diagnosis, because other causes of secondary PAP is unusual at such an early age. Now, in this child, liquid chromatography was done, and it showed that there was low arginine, ornithine, and lysine. And the urine showed increased excretion of lysine, ornithine, and arginine. So this is a specific entity which is called lysinuric protein intolerance, in which the child is not able to tolerate a few amino acids, lysine, ornithine, and arginine. And because they are present in the normal food, so they get the child presents very early in infancy with the appearance of interstitial lung disease, chronic kidney disease, neurologic involvement. And in this child, a pathogenic variant was found in a specific gene, which could imply this specific disease called lysinuric protein intolerance. Now, in a PAP, pulmonary alveolar proteinosis in a child, why do we need to do genomics? Do we need to do genomics? Yes, because if you just go through this list, a very exhaustive list, which shows so many genetic mutations are already associated with childhood interstitial ILDs. So here we are talking about this gene, which gives rise to pulmonary alveolar proteinosis with lysinuric protein intolerance. Now, of them, this is the pulmonary alveolar proteinosis group, in which we can see the causes of pulmonary alveolar proteinosis pattern on HRCT in a child. We are not talking about adults here. We are talking about a child. The causes, what may be the causes? The causes may be this variable. So why do we need to know? Because if we keep on doing lung lavages, which is otherwise the first line treatment for these children, it is not going to yield any result. Rather, dietary modification and specific diet is the key to treatment in these children. Other than this entity, there are many other causes, including immune deficiency, other genetic causes, and the disorders of surfactant protein metabolism, surfactant and autoimmunity. So there are other causes of PAP in childhood. So childhood ILD diagnosis is expanding, and every day almost like a new knowledge is being added to it. So we should move to the radiogenomic era in cases of childhood ILD. Why do we need specific diagnosis? Most of the time their prognosis is bad. We're not going to give a specific therapy. So then why the need to know? Because apart from symptomatic treatment, specific treatment is available for some conditions. Like usually antifibrotics like we use in the adults, they are not widely used in children. Only 1 or 2 trials are going on. However, like in our case, if we knew that this is because of lysinuric protein intolerance, a dietary modification is going to help rather than some other approach. So there is definitely a need for specific diagnosis in childhood ILD. Now, coming to another case, this is a 2-year-old boy who presented with a long-standing fever, who was diagnosed with TALL on bone marrow biopsy and received induction chemo in March 2022, placed on methotrexate maintenance therapy. So this was at the beginning, at the diagnosis in February, when we saw that the test was clear. Subsequently, what happened? The child developed fever and tachypnea on 3rd May 2022. What we can see is that back-to-wing pattern of bilateral diffuse consolidation and GGO. A CT was done, we could see the GGO much better. It was perihilar, and at some places it was peripheral as well. Not exactly, it was not sparing the periphery, but anyway, the bases were being spared. And the nasopharyngeal aspirate showed positivity for pneumocystis jirovecii. So pneumocystis pneumonia was confirmed at that time. So here is the chronological appearances of the chest radiograph. So February, March, April, and in May the child had pneumocystis pneumonia. Now, from now onwards, if we see, in 15 days, the densities did not subside when the child was already on treatment. And they went on being even denser. On 25th of July, we could see that density is much more denser, almost like that of bone. Now, this was confusing as the child received treatment for pneumocystis pneumonia. Once we did CT, we could see very peculiar finding of this confluent pulmonary airspace opacities, which looked very, very dense, like calcification, because this was a CT. So outrightly calling it calcification was not possible. However, when we measured the HCO value, it definitely showed that this is calcification. So there is diffuse calcification within the pulmonary parenchyma in a typical pattern where exactly the pneumonic affection was there. So where exactly the pneumocystis pneumonia were exactly in the same location, now we are getting parenchymal calcification. So the next question is, what is the calcium level? So there was a transient hypercalcemia at the time of induction here. The calcium was 13, but immediately thereafter, it reverted back to normal level. So the possibility was, if it is not hypercalcemia with metastatic calcification, then it is dystrophic calcification. So this dystrophic calcification probably happened after pneumocystis, carrying pneumocystis pneumonia. Methotrexate toxicity was also a possibility, but methotrexate, when the child was on induction, then this developed. So methotrexate probably was not the causative factor. And moreover, the typical distribution of the calcification in the areas where they were earlier affected by pneumocystis point towards dystrophic calcification in pneumocystis pneumonia. So dystrophic calcification or lung calcification, so it can be seen after viral pneumonia or in the context of hemosiderosis, pneumoconiosis, amyloid, or other causes. 10-year-old boy who had a history of dysphagia. And here we are seeing the chest radiograph. What we see is that the indentation on the trachea. So the trachea shows a mass effect from the right side. Okay. And this left main bronchus was normal, so is the right main bronchus. But there is definite narrowing of the trachea over here. Bilateral lung fields, they were showing hyperinflation. The diaphragm domes are flattened. Now the child presented with dysphagia. So a barium swallow was done. What we see is distended or dilated esophagus at the upper part, upper thoracic part, whereas at the lower thoracic part, there is a smooth, subtle narrowing at the distal thoracic esophagus. And since this was an older child who could cooperate to get an MRI done, we went ahead to do an MRI. And in the MRI, T2 weighted images, we could see that there is a diffuse soft tissue which is encasing the trachea, encasing the esophagus, also the aorta. See, this tissue is very T2 hypointense. If in the second image, we could see that aortic lumen, and just around it, we could see this very T2 hypointense structure. Also, similar structure was seen in the left hilum, around the trachea, pretracheal, precarinal location, in the prevascular space. Contrast was given. This is the arterial phase, and subsequent dynamic images showed that there is enhancement. The delayed images showed avid enhancement in the tissue, suggesting that probably there is mediastinal fibrosis that is going on. Now, mediastinal fibrosis, which was showing enhancement, and a biopsy was done from this. So this was the appearance of that mediastinal fibrosis. Biopsy revealed Aspergillus fumigatus. The child was started on voriconazole, and the respective images, the follow-up images, we could see that. So January and April images. So this is the, sorry, the labeling is wrong. So this is the January image. This is the April image. So you can see that the amount of soft tissue around the esophagus, it has reduced. Amount of soft tissue around the aorta, it has also reduced. So January scan and the April scan, this amount of soft tissue and the narrowing of the left main bronchus that was there earlier in January, that has resolved in the after the treatment. So mediastinal fibrosis itself can cause, mediastinal fibrosis can be caused by many other, many diseases like tuberculosis, like fungal infections, as Here we can see in aspergillus. Histoplasmosis is also known. IgG4 related disease is yet another cause. Now, when in a child, if we see such kind of mediastinal soft tissue, the challenge is to differentiate between a lymphoma versus mediastinal fibrosis. Now, diffusion weighted images can help in this situation, and also the pattern of enhancement and extreme T2 hypointensity, they are also in favor of a mediastinal fibrosis over lymphoma. I will end today's discussion with this short last case. So this was a 2-year-old girl who had a history of occasional streaky hemoptysis. So an chest X-ray was done. Something was shown over there, which I'll show later. The next investigation was an echocardiography, which showed a mass. Now, if we see the CT images, we could see these are the vessels. This is the main pulmonary artery. This is the ascending aorta, and there is a densely calcified lesion which is lying between the superior vena cava and the aorta. It is the same lesion can be seen into the interventricular, atrioventricular groove location. Also, if we look at the coronal reformated bone window images, we could see that it is kind of going within the pericardial recesses, within the pericardial cavity. Otherwise, no mediastinal mass would have taken such a shape, like going within the, going between the IVC and the aorta, as well as going within the atrioventricular sulcus. So these are the coronal images showing the shape of the lesion. So clearly, this is an intrapericardial lesion, which is showing a heavy calcification. So there is dense calcification within the lesion along with some soft tissue component. So this is the volume rendered image. Because of this extreme high density of calcification, the images are not that good. We could see that the way it is going and taking the shape of the pericardial recesses. So the possibility of a pericardial teratoma was kept. Now, primary pericardial tumors are rare in children. Teratoma is even uncommon within the pericardial cavity, but when present, they might present with compressive symptoms on the cardiac chambers. Otherwise, they are benign. A complete resection has a good prognosis. So with this, I end my discussion today. Thank you all for your patient hearing, and this is Delhi.
Thank you, Dr. Manisha, for the very interesting cases. And some of the cases are really very rare. You rightly said once in a lifetime cases. Here.
Ravi, one message which Manisha brought out very nicely was that, you know, what we are trying to say, that ultrasound before CT and ultrasound after CT, you know? You want to say anything more on that, Manisha, that what all role ultrasound can fulfill?
Yes, ma'am.
Means, yeah, when is the time, like instead of repeating a CT, you may want to do ultrasound like that, no?
Yes, ma'am. We would like to do both before CT. Maybe sometimes if we see the mass is very vascular, we may plan a CT angio rather than a routine CT. If the CT is, if a pre-existing CT is of not optimal quality, suboptimal quality, in that case, or in follow-up of nodes, tubercular nodes or masses, which can be seen on ultrasound.
And if you're outside that suboptimal CT, if done elsewhere, instead of repeating a CT, yes, many times, you know, you may be able to get away with the ultrasound. So she showed very nice ultrasound images. So even if you don't get calls for bedside ultrasounds, there's a lot of ultrasound to be done in, you know, semi-elective and elective settings also.
Yes, ma'am.
Okay. Thank you, Dr. Ashu. Dr. Aparna, you would like to add something? Dr. Aparna?
Thank you, ma'am. Thank you so much, Dr. Manisha. It was such an awesome session with so many nice cases we saw today and learned so much. especially the use of ultrasound, MRI, and everything, how you put together everything to make the diagnosis. It was really excellent. Thank you so much.
Thank you, ma'am.
I also wish to thank Clernet for helping us with this webinar. Miss Ananya and Miss Shweta, thank you so much. Thank you all the people who have attended. I hope you all enjoyed it. We'll get back to you with more webinars. Thank you.